enthusiastic refractive surgeon from Pune, who would set the ball rolling with a review of literature on why PRK is superior to flap in a 500 micron cornea. On to you, Vardhaman.
Thank you, ma'am. I will just share my screen.
All of us have to remember that our talks are for 5 minutes, and at 4th minute, Mr. Sunil will give us a warning, and we should close by 5 minutes.
My screen visible?
We can see it.
Yeah, okay. First of all, thank you, Dr. Chitra ma'am. What I'm going to speak to you about is going to be some review of literature about why the PRK or surface ablation is superior to LASIK procedure in a thin cornea, which is 500 micron. Friends, we all know that basically when we are talking about 500 micron cornea, we are specifically looking at the safety aspect of the refractive procedure amongst the predictability, safety, efficacy, and stability. The safety becomes of paramount importance in this regard at this thickness. So the burning questions are, does the thinner cornea mean a biomechanically weaker cornea inherently? Does PRK induce less biomechanical weakening as compared to LASIK procedure? Is PRK so in turn inherently less prone for ectasia than LASIK surgery? And what about safety, predictability, efficacy, and stability of PRK in thin cornea in general? So does the thinner cornea mean biomechanically weaker cornea? As we all know, in refractive surgery, when it comes to the newer way of investigating these patients preoperatively, the biomechanics is playing a very big role. And this has been shown time and again by variety of studies that generally the central corneal thickness and the biomechanical parameters, they correspond. Of course, we have always seen exceptions to that, such as having people having 550, 600, even 570 micron cornea with keratoconus. And we have also seen, on the contrary, about 460 micron cornea, which have been stable in long term. But generally, yes, the thinner cornea means that probably a biomechanically weaker cornea. So does the thinner cornea mean a higher probability of ectasia after corneal refractive surgery? So I think this factor has been looked at time and again, and low preoperative corneal thickness has been seen to be a significant risk factor for ectasia in general, especially in the ectasia risk scoring system by Randleman et al. They have seen in their cohort of patients when patients had less CCT preoperatively as compared to the cohort which had normal outcomes postoperatively, the thinner cornea was a significant risk factor. Of course, the thinner cornea is a risk factor which is probably much below the most important topographical pattern, which is most probably the most important factor when it comes to the possibility of ectasia. The third question is that does PRK induce less biomechanical weakening than LASIK surgery? So yes, intuitively, as we understand that in PRK, as against in LASIK, we do not have a flap. And the studies have also already shown that the flap itself does not contribute to the biomechanical strength post Lasik per se. So in PRK, definitely we are preserving more cornea. Uh, the the specifications such as residual bed thickness and the PTA score has been more in term with LASIK. But even if we talk in general, definitely in PRK, we are actually managing to keep a more stronger cornea behind. This has been seen by a variety of published literature already, which have looked at the corpus as well as ORA studies in which they have shown that PRK definitely is much lesser invasive than in LASIK when it comes to the biomechanical stability in post-refractive surgery eyes. So is PRK also inherently less prone for ectasia than in LASIK? Definitely, there are much lesser reports of ectasia in PRK. So this was one meta-analysis which looked at this, and they have seen that out of 31,000 eyes, only 9 eyes had developed post-PRK ectasia, which was 0.029% of incidence, versus post-LASIK ectasia has been seen to be reported from 0.1 to 0.66%, so substantially higher. And again, a variety of reasons have been given for that regarding the same, including keeping the better tensile strength, not touching the anterior stroma too much by not cutting the flap. And of course, what has also been seen is that apart from much lesser reports of PRK, whenever the ectasia has been reported in PRK,
1 minute left.
Majority of this ectasias have been reported after the first year. So only 10% had represented in the first year, as against in LASIK, more than 50% actually have presented in the first year itself. The most important thing is this contralateral case report. There have been 3 case reports in which one eye has undergone Lasik and the other eye has undergone PRK. In this procedure, the Lasik eye actually went on to develop ECTASIA and the PRK eye did not develop a full-blown ECTASIA. In one of the first published reports by my mentor, Professor Kalikaris, then there was another report from Middle East by Zavedi et al. And one of the best documented reports is from India by Dr. Prema Padmanabhan Madam. And as you can see very clearly, this was the preoperative scan of this patient. In the right eye, there was this superior inferior asymmetry. The left eye actually had much lesser asymmetry. So they actually performed a surface ablation on the right eye and they performed a LASIK procedure on the left eye with a corneal thickness of 500 micron. And the left eye actually went on to have a full-blown ectasia, where the right eye actually, much stable results. My last slide is basically the PRK has, in thin corneas, has also shown a great amount of safety, stability, efficacy, and predictability as compared to PRK in normal thickness corneas in this 10-year follow-up study, which was published by George Alio. But of course, the last thing is that if you have asymmetric steepening or skewed radial axis, high myopia, residual bed thickness less than 400 micron, then today, even if you have a 500 micron cornea, phakic IOL should be your procedure of choice. Thank you very much for your kind attention.
Thank you, Vardhaman. You were concise and brief and told us all. One question I would ask is, what would be your upper limit for doing PRK in a thinner cornea?
So, ma'am, I want to leave behind 400 micron cornea. So my upper limit will depend on how much ablation I have to do. So I typically don't go beyond -8 diopters in surface ablation per se, generally speaking. So I have to have that marriage of the amount of spherical equivalent that I'm trying to treat and leaving behind 400 micron cornea at the same time also. So I think whatever the equipment allows me to do, I will go for that.
With a -8, what is the duration of mitomycin which you would use?
Ma'am, for -8, I'm using 30 seconds as the duration for mitomycin C. Otherwise, for myopia less than 3 diopters, I'm using 12 seconds mitomycin C.
Dr. Praveen, you have something to add? Because I think there is some issue here about different timings for many of us. I would, of course, prefer to keep it to -5, and very rarely, there's no other option, would I even consider a -6. I would, I normally would keep it at 30 seconds, mitomycin. But I think Dr. Praveen is on. Are you there?
Yeah, I'm here, Chitra. And
I think you have yeah.
No, thanks for the question. We've actually looked at our results over 11,000 cases, myopia up to -12. And when we looked at the results of PRK and high myopia, 0 to 3 diopters of myopia is equivalent to 6 to 9 diopters. There's no difference in the visual outcome or the stability. Between 9 and 12, the accuracy is a little lower. The stability is a little lower. So I think up to 9 would probably be a safe limit. And mitomycin C, we use a sliding scale, 1 diopter for every 10 seconds, and that seems to be working very well.
Anybody else in the expert panel have anything to add on this?
Vardhaman said that you need to have 400 microns left. So if you have a 450 cornea, because her question, Chitra's question was, what is the least corneal thickness that you would take? So if you have a 450 cornea and a -4 diopters, would you do it?
No, sir, definitely not. I think less than 480 microns, I would probably.
480. Your cutout is 480. That was what
cutout is 480 for such an application.
Okay.
I mean, you can't definitely be hard and fast in that rule because it depends upon the age also. If you have an elderly patient with perfectly normal symmetrical topography, then even 450 microns is fine to treat. I mean, so you have to consider all the parameters before taking a decision. And I think above 350 microns also is fine in elderly patients. If they are over 35 or 40 years, then the cornea remains quite stable.
Yeah, I think I will agree. If it is probably younger female, then I think it is better to be more, let's say, preventive. And if it is an older male, probably you can go further than the statistics.
Thanks for mentioning this because people do it but don't want to mention in a conference. I appreciate what you taking the lead to say that. I appreciate what you're saying. That's exactly.
And even mitomycin, see, it depends. Like if I have a post LASIK or post-smile patient which I have to enhance, then we don't necessarily go by that rule. And I generally like to use mitomycin for a longer period of time because the haze is more. Yeah.
Yes, I agree.
For me, the take-home message from this very nice review is that if in doubt and if you still want to do LVC and the patient qualifies for it, go for PRK. And we have Lasik, we have Smile, etc. But as far as safety is concerned, still PRK is the king. And in case you are combining it with collagen cross-linkage, still I think that's most scientifically, intuitively right. And for us, we use mitomycin C for 30 seconds, irrespective of the amount of power that we are treating. And it has worked well for us and with hardly any documented side effects and very little haze.
Dr. Chitra, I am audible.
Yes, you are audible.
Yeah, my fault. See, I think the first important step is how you really remove the epithelium, whether you are using manual or alcohol or viscoelastic or it's a trans-PRK. Then how really you use mitomycin. Any spillover from the cornea is going to give you a trouble, whether you use it for 30 seconds or whether you're using it for extra second. And that makes the difference. The complications do not occur because of PRK. The complications occur because of more of the chemicals we are using to complete the surgery of PRK.
Yes. Any other questions before we move on to the next